topic of this Grand Rounds is COVID-19. That's the disease, coronavirus infectious disease 19. The name of the virus, just to settle things out if you read about it, is SARS-CoV-2. It has that name because it is very closely related to the original SARS virus. It's an RNA virus, like SARS, originated in bats. They use the same host cell receptor, which is angiotensin-converting enzyme 2. Of note is that the gene for the RNA-directed RNA polymerase of the two has 96% identity, which provides a potential therapeutic target for all of us. This is from yesterday. This is actually the Johns Hopkins site with the dashboard, and basically you can see that we have just about reached 1,000 cases in the United States, that the overall numbers of cases in China have slowed down dramatically, but the rest of the world is starting to catch up. As I said, I wanted to jump ahead to the therapies because we have chosen one of these for investigation. A variety of drugs have been suggested. I'll talk about remdesivir, chloroquine, or hydroxychloroquine, but let me just talk about remdesivir. So this is a nucleotide analog. It's actually a prodrug. It was studied in Ebola in the clinical trials, but it failed versus 2 monoclonal antibodies that were eventually approved for treatment of Ebola. And as I said, it has close sequence identity in its RNA-dependent RNA polymerase between SARS and SARS-CoV-2. And it is active in animal models of SARS-CoV and also MERS-CoV, which of course is the Middle East respiratory syndrome virus, in which camels are thought to be the source. We are obtaining this drug for expanded access use currently, and we are about to become part of Gilead, which is the pharmaceutical company down the road that has this drug, of their clinical trials. So this is, for now, our preferred agent. We've looked into others, such as interferon lambda, et cetera, but this is the drug that we will be recommending and hopefully enrolling patients in the clinical trial.
I wanted to share the perspective of what we're seeing at the front lines, emergency department being the literal front door to the hospital. I wanted to share the perspective of what we're seeing, what we're doing to put systems in place to appropriately screen patients, and then touch a little bit on what the hospital is doing in response to increasing numbers of the PUIs and COVID-positive patients. Our strategy for the emergency department is to try to avoid utilizing the rate-limiting step in our department, which is the negative pressure rooms. Under the current guidelines for respiratory isolation, airborne precautions, we have a limited number of negative pressure rooms. We have 4 in the 500P and 2 in 300P, the pediatric ED. We've since split. And so our strategy is try to minimize the use of those to those who truly, truly need it. And to do so, we've moved up the screening process, much more proximal in the process. In the current state, if you showed up with influenza-like illness, you'd be screened by the security person in front of the metal detector for fever, cough, shortness of breath, etc. Now we've actually moved a nurse out front by where the valet comes in, by the parking area, in full PPE to do the screening. We also have a physician in the lobby that we've had before for 16 hours a day. That's also the sole resource for that nurse to help screen. And the goal is that if you identify someone who's a PUI, you don't bring him into the lobby. You bring him around to our negative pressure rooms through the side. This quote-unquote drive-through model is something that we are putting in more formally actually this week. So in fact, later this morning, we are putting together a group from a disaster preparedness perspective to implement a model so that those that come in, we can rapidly screen. These are not the ones that are severely sick. If they're very sick, they automatically need to come into our department. But for those that meet the criteria, they can get rapidly swabbed, assessed, screened, swabbed, and then they can actually go home, where we will have a system to follow up. This model has been implemented elsewhere, other states. Rhode Island, I just saw an article yesterday that they were doing something similar. Other countries, South Korea. As part of this model, we took some lessons that we learned from 2009 H1N1 seasonal flu, where we simulated a model just like this, and it was actually published. And so we're taking some of the lessons from that from other places and putting that together. Once a patient makes it into our emergency department, if we run out of negative pressure rooms, we've been using closed doors with HEPA filters. And then what's been nice is that as we've now developed a process working with the Department of Medicine with the hospice team, those patients now go to a dedicated unit. And so the B1 unit is now dedicated for PUIs. And that ability to co-locate those patients has dramatically improved in terms of efficiencies, conservation of PPEs, and things like that. If patients are sick enough that they need ICU level of care, they would still go to an ICU because there are negative pressure rooms. The other aspect of the screening I want to touch on beyond the ED is what's happening in Express Care and Occ Health. So these are the three entities that will be seeing oftentimes the ambulatory patients who have been exposed with symptoms. And so the Express Care has developed a model similar to, again, to the drive-through model that started this past Monday, where patients who are screened for potential PUI or potential COVID through a video visit will now have a sample swabbed in the parking area outside of the Hoover Pavilion. The third component is Occ Health. There's been a lot of challenges for Occ Health. As you imagine, it's been completely overwhelmed by the amount of demand. And so that Occ Health department has significantly been provided a lot of resources this week, so it's been scaling up to be able to meet the demand. But eventually, they will also be able to test healthcare workers based on a similar criteria. So again, the goal is that these are the 3 points that people can get tested, because we do want to increase the amount of testing. When we first started, we stuck to the very specific CDC criteria. So if you were exposed to a confirmed positive with fever or ILI symptoms, that's one criteria. Or if you travel from one of the 5 index countries, the tier 3 countries, with symptoms, and you required hospitalization, or you have no source of contact or infection, but you require hospitalization with fever and symptoms. Those are the 3 criteria that we currently have in place. We are likely going to be expanding that criteria this week, because prior to having the lab testing, it was restricted at the level of the county. But knowing that we have the ability to scale up the testing to 300 samples a day, eventually 1,000, we definitely want to test more people. And by broadening criteria, we'll be able to do so.
I wanted to tell you how our hospital is developing all of these protocols. First of all, we have activated essentially an emergency operations center. It's called the COST meeting. It doesn't have anything to do with cost, and don't ask me what COST stands for because I can't remember. But that meeting takes place every day, and we have an agenda to look at and to go through for an hour every single day. The COST meeting is designed to bring forward, to adopt certain suggestions and documents that have been brought forth from the previous day, to say this is what's going to go onto the intranet. We're using the intranet as our source of truth. It's being updated daily, and it's really coming through the COST Center. These are the group of people who have to essentially say, yes, this is how we're going to operate today. In the meantime, many people are given, in fact, everybody on that committee is given multiple assignments to work on, to develop another policy. How are we going to use occupational health? Obviously, the director of occupational health is a key member of that committee. And then in addition to that, Sam Shen and Megan Mahoney have a larger group of clinicians who are also meeting every single day to discuss clinical issues, and they relate up to the COST meeting in the morning. And so we do have essentially operations command center going. It's in the form of the COST committee and then all of the working groups. I must say that virtually all of us who are on the COST committee are working about 20 hours a day. Sometimes I think Dr. Risk never gets to sleep. And so we're in constant communication with each other. And it's as Dan said, it's a fast-moving target. The signs are more subtle. So what I wanted to discuss this morning is what we expect from all of you, our providers, our healthcare workers. First of all, go onto the Santa Clara website and get information for the public, how to protect yourself Social distancing has a lot more elements to it than the 6 feet. And I can't spend the time to describe all of those, but these are things that the kids are being taught. It's all over the media, and it's on the Santa Clara County Public Health Department's website, questions, what should I do to keep myself safe? So obviously, we want you to keep yourself safe because we need you to come and take care of our patients. And so we expect every person who comes to work in the entire enterprise to monitor themselves before they come to work. If you feel you have a fever or you take your temperature, and I hope every one of you has a thermometer, but they're hard to find these days, do not come to work. We expect you to monitor yourself for fever or cough or shortness of breath or sore throat. Now, I know there's a whole lot of in between there, but those are the things that we'd like you to at least say, I don't have any of those. Once that's happened, if you have any of those other symptoms besides fever, then you really do need to notify OCHealth immediately. And if you have a fever, obviously they're going to tell you if you've already come in. You need to go home, and they will determine if COVID testing is indicated. You will know that. If you have a cough or shortness of breath or sore throat without a fever, and you've touched base with occupational health, you can continue to work wearing a surgical mask for your entire shift. You have to practice good hand hygiene, and wear gloves is our standard precaution, and obviously you have to change gloves every time you do hand hygiene and between patients. That's standard work. What to do if you are a person who has had an exposure to someone with COVID-19, I'm calling it COVID-19. And so again, as Stan said, that's someone who's defined as a healthcare provider who's had close contact within 6 feet for more than 2 minutes. This is CDC's guidance, defined as a potential contact. However, we have decided if a patient's in an airborne room, which we still have a lot of them, and you are wearing all the proper PPE and you've seen the patient and done it all, you may continue to return to work. You do not need to contact OCHealth. We are assuming you are safe. The number for the fever is 100 or greater. But the idea is that if you have these other lower grade symptoms without a fever, you can continue to work with a surgical mask. You do not have to go into self-quarantine. And that includes people who live with a person who has documented COVID-19. And we've had a couple of instances already, and those people do not need to be quarantined, but they do have to self-monitor every single day, touch base with occupational health, and they can return to work. And I think that's really important to say because we need people to come to work and to take care of our patients. Otherwise, we can't, follow our oaths to care for the sick and the needy.
And that is, you're making the assumption that asymptomatic transmission doesn't occur.
Yes, we are.
But it, of course, has reported to have occurred.
Yes. Dan, we had to make some assumptions, and that's essentially the guidance from the CDC. Yes, there probably is asymptomatic transmission, but we simply can't work if we're just worried about asymptomatic transmission. And so we can't test everyone who's asymptomatic. That's clear. Not all of our healthcare workers can be tested just because they're asymptomatic. And so, yes, we might miss somebody who's asymptomatic, but this is the only way we can analyze this.
So the issue around testing asymptomatics exposed people is that you don't have a guarantee that tomorrow that patient won't then be shedding. So Marissa Holobar and Lucy Tompkins and I have spent many hours talking about this, and we agree there may be a low risk of asymptomatic transmission, but just a negative test today doesn't mean that you have a negative test tomorrow. We haven't seen evidence of that happening yet. And unless we have evidence to the other contrary or CDC tells us to do that, at this point, that would mean you'd have to test somebody every day for 14 days. And we're not quite ready to do that yet unless we get guidance from the federal or other public health authorities.
So I say we are currently screening for both. So if you're concerned about COVID, you are getting the full respiratory panel. And our protocol in the ED is that you don't wait and for the flu A or B or RSV, looking for alternative diagnosis. If you're concerned enough, you get both at the same time. And even if the flu A comes back positive, you still maintain the same precautions as if you were potentially taking care of a COVID patient. And that occurs as we admit the patient from the ED to the inpatient as well.
We have had one co-infection so far with rhinovirus, which is not particularly surprising.
So first off, I want to thank everybody for not showing up today. We currently have over 1,000 people on the Zoom chat. We have amazing grand rounds all the time, and we never get this level of interest in our topics. The last time with this level of excitement for grand rounds was about 10 years ago during the swine flu epidemic. No surprise. So it's very unique, this scenario we're in right now. The recent topic we were just talking about, asymptomatic transmission, I think really hits home at kind of the theme we're getting as the most popular questions. And guys, we have over 90 questions right now. The first one is really talking about what's our threshold for testing. So as there is more data coming from China and other places that symptoms can be mild and don't have fever presentation, what is the threshold for testing now that is more widely available? Also, Steve Goodman asks a similar question. From Stanford website, it appears the only people who will be tested are those who are strongly symptomatic. But for the purpose of quarantine and prevention, can it be as important to be testing mildly symptomatic people who spread the disease to close contacts? When will Stanford be doing when will they expand local testing?
We are expanding local testing as much as our virology lab can accept. And so the suspicion index is going to continue to change, I believe. We use right now fever or cough or shortness of breath or sore throat. We know that there's lots of URIs out here, and that's why occupational health will be your first point of contact. They will assess just what are your symptoms? Is it just you've got some postnasal drip and you're congested? I believe they would tell you can return to work wearing a surgical mask. But that's our point, and every day we will be updating occupational health. They're members of the cost committee, and we'll adjust the definitions as we need to.
But based on our case uptake thus far in the immediate Santa Clara County, do we have estimations as for what we might expect the outbreak incidence curve and when we can expect that surge number of cases? So what can we expect as of now as far as the number of cases and when?
We don't right now have information about surge. We're looking around the world and looking, as you all are as well, and seeing different patterns of disease. And we suspect that it has to do with the transmissibility of the pathogen and the ability to do what you're doing now, which is social distancing, so decreasing the amount of transmission. Some of you have heard Tony Fauci from NIH talk about flattening the epidemic curve. So what we probably saw in China was an explosive growth because it wasn't detected for several weeks to months beforehand. What happened in the U.S., probably because of quarantine, et cetera, in China and other places, and our restriction of travel, is that we're seeing a flattening of the epidemic in the U.S. So we probably will see more prolonged disease in the U.S., but we hope it won't get to that peak. We've also instituted testing, so our sense is that it won't be rapid, but it may actually reach a level where we will be able to build up our medical capacity to handle cases because it won't be as explosive. So, but we, again, don't know. We don't know when it's going to end. It's probably not going to be April, but we don't know exactly what's going to happen. And then the other question, of course, is whether it will be seasonal, whether will it be long-term, year-round, et cetera. Again, don't know the answer to those questions.
We'll jump over to this question that kind of goes along with it. Since the U.S. hasn't been testing systematically, how reliable is the curve of spread? So I think the take-home message is tough to know right now because we don't have the data.
It hasn't been enough testing. That's the problem.
And, we're all community dwellers as well. That's why I really wanted everybody to say, you have an obligation to yourself and to your family to protect yourself. I'm not traveling on commercial aircraft, even though they're doing their very best to keep them clean. They have HEPA-filtered air and so forth. If you're sitting next to somebody who has this virus, your chances are pretty good. So I'm avoiding large groups, and I think it's great that Bob has made the decision that this is going to be a virtual Grand Rounds. We have a mission of learning and teaching and information that we must continue here. Our university is not closing, our medical school, our hospital will never close. And so we need to continue to have everybody be able to work.
How long can the virus stay alive without a human host? And someone asked, can it stay alive on things like vegetables? And if you eat it, is it dangerous?
Oh, no, but it is important to point out that this virus does last on surfaces for several days. And so that's why the contact precautions, that is washing your hands, disinfecting, surfaces, doorknobs, your microwave at home. I use a towel to open the doors, paper towel to open the doors around here, so I don't have to touch the common such surfaces in the hospital, and same thing at home. And so that is an important part of coronaviruses in general, is that they can last in the environment on surfaces. Now, about eating, as far as I know, there's no evidence that you can acquire the infection by eating food.
What about eating out at restaurants, coffee shops, etc.?
I'm taking my family out to dinner on Saturday. I don't think the people at the next table, nobody in my family who's ill is coming to dinner. And so I don't think the people at the next table, they'll be farther than 6 feet away. I wouldn't go to a bar.
Okay, fair enough. Another question here. I understand that data in pregnant women are currently limited. But what about the prognosis for women who are expecting? Should they do anything over the course of the 9 months during this outbreak?
Avoid being infected. The data is limited in pregnancy so far. The very limited data suggests that there's no increased risk of severity of illness as there has been, for instance, with influenza virus.
So we've looked at data, published and unpublished data from China, and quite a number of women pregnant have been infected with no untoward symptoms so far, and their infants appear. There is evidence of potential vertical transmission, probably postpartum, but those children have all done well.
That's one of the mysteries, is why the children are less commonly infected and why they all seem to do well. I don't think anybody has any good understanding of that.
So Wuhan underwent complete lockdown at some 500 infections and a dozen deaths, yet their cases continue to skyrocket in the next couple of weeks. Are we past that point, and are we doing enough? Tough question to answer.
I don't think anybody knows. I think, as Bonnie said, Dr. Tony Fauci, feels that we can flatten the curve, which means if we use all the social distancing and everything else, that we can flatten the curve. It won't be like the explosive outbreak in Wuhan, because we've had a fair amount of advance notice, and we are all the hospitals and organizations are planning something like COST, if they don't call it incident command. And so flattening it out means it'll last longer, but fewer people will become infected. And we certainly won't see, I don't think we'll ever see, the scenes of, building new hospitals to accommodate patients. The other thing about China is they don't have they don't have primary care. They have nothing between, the drugs, the pharmacist and the hospital. So they have a completely different healthcare system, which is obviously completely inadequate. We have primary care. We have physicians in the community, to manage patients, and so that's. I think not going to be. We're not going to be anything like China. What we're going to be like, I don't know.
Should we be advising older adults to stay at home from adult daycare centers for older adults with dementia? They're clearly vulnerable, but the county health departments have not closed them, and they provide meals and needed care.
I mean, I think the whole point is that every contact with another human being increases your risk very, very tiny amount. In data looking at exposures in the United States, the transmission rate to close contacts, symptomatic transmission rate, so this misses the asymptomatic transmissions, is 0.45%. Transmissions to household contacts was 10.5%. So it's a matter of coming into contact with someone and the amount of time and intimacy of that contact. It's obvious. I mean, it's just probabilistic theory. So those people are at increased risk, and they happen to be a group of people who are at increased risk of dying. And to the extent that care can be found for them, because it might not be possible for those families to bring those elderly people back home during those days. Somebody has to put food on the table. Everybody has to deal with that individually. And if the county decides at some point that the risk is too great, then everybody will have to deal with it.
Thank you for viewing. Thank you, Errol, for setting it up. And thank you to the panelists.